They got a lot faster, software is better. So there was really an evolution over that period of 15 years. And but you know, not everybody's doing his knees navigated. I know in India you have a lot of navigation systems, but a lot of them are maybe in the corner, so not frequently used. So why is that? And I think that is important to highlight before anyone starts thinking about investing in a robot. So one of the problems was that there is a learning curve. So for robotic systems as well as for navigation systems, you need to have certain numbers of cases before you really understand what the machine is telling you. And that number depends a bit on the study you read. So here it is only 7 or 8 cases, but in a lot of other studies it's around 30 cases. So then it depends, of course, a bit on how many cases you do per week. So how long is my learning curve? So the consequence from the navigation side at that time, yes, it is a successful tool, but probably more in high volume centers, and it's a yes or no decision. So if you go for navigation, you navigate all the knees, otherwise you should navigate none of the knees, because if you bring the machine in only for the difficult ones, you will never achieve the turning point of your learning curve. So I think that was something we have learned over the last decade. The other problem with the systems were, and I think with the robotic systems now they're even worse, is the topic of cost. So a proper navigation system in Europe costs around 100,000 euros. And you have additional software updates every 2 or 3 years. And of course you have daily costs for reflectors and all that stuff. When it comes to robotics, the price is a lot higher. So depends a bit on the system you want to buy. It's in Europe, it's around 500,000 to 1 million. So that's a huge investment plus the daily costs. So that is overall extra cost per case between 600 and 2,500 euros per knee. That's quite a lot, and again, it is only really helpful if you do that in high volume centers. Third part is outcome. There's an ongoing discussion whether it is really beneficial to invest in all this technology. Because some say, yes, it is helpful. So there are studies there, like this study from Switzerland, where they have shown, and it's 10 years back, they have shown at that time, that if you do it with a ligament referencing technique, that CAS gives you better outcome compared to conventional technique. And if you look at the Australian registry data, they have shown now for 4 years in a row that especially in young patients, the revision rate with navigated or robotic performed knees is lower compared to the conventional surgery. So there is data there, but on the other hand, there is also data there that there's no difference in functional results at 2 years. So what is definitely proven is that the precision is improved with the help of technology. So if you want to cut 0, you cut 0. If you want to cut 7 millimeters, you cut 7 millimeters. But what we also have learned that this precision alone is not solving our problem of unsatisfied patient in a percentage of around 10 to 20%. So there must be some other factors, and that is what we are discussing now in a lot of conferences over the last 2 to 3 years. So maybe there's a need for a more individual solution. So bringing all knees to neutral alignment and making all gaps equal is maybe not the right goal for all the patients. So we need to better understand the knees and then find individual solutions. And there are a lot of solutions out there, and I don't want to confuse you with that slide, but it is really a bit confusing. Nowadays you have so many options how you can put in a knee. So classical is mechanical alignment, whether you do it tibia first or femur first. But there are, as you see here, for the tibia first surgeons, there are a lot of other options. You can do adjusted mechanical alignment, constitutional varus, anatomical alignment, inverse kinematic alignment, or patient-specific alignment. If you're femur first, you can do kinematic alignment or restricted kinematic. And each of these alignment workflows has, per definition, different decisions at different steps of the surgery. So maybe the tibia cut is not zero in some of the alignment philosophies. It depends on the MPTA, or as defined with 2 or 3 degrees. Maybe your distal femoral cut is different. The rotation definitely is different in a lot of knees. And also the balancing goals. So if you look at kinematic alignment or patient-specific alignment, the goal is not to balance the knees all 4 gaps equal. They want to leave the lateral flexion gap a bit larger than the medial one. And why is that? Because the great majority of natural knees have the lateral flexion gap a bit larger. So this is why they want to keep it there a bit more lax. So new goals, new definitions, why it's difficult to move from one philosophy that you have performed for decades to another one. And the other challenge what we have nowadays for the learning curve is that when you move to a robotic system or navigation system, which is more or less the same at the moment, except that one has an additional arm for the saw, is that you see a lot of numbers now on the monitors. And that interpretation of the numbers and how to plan your implant in the right position, that makes it really difficult. So it's a combination of changing to a new alignment philosophy, and then if you want to change with a new tool like a robot, again a learning curve. So what is required for executing an individual plan? It's precision. So if you want to cut your tibia in 2 degrees of varus, you have to really be precise. And there are studies out there that have shown that if you want to do that with conventional technique, so you want to cut your tibia in 2 degrees of varus, in 40% you cut it far more in varus than what you have planned. So it's an additional 3 degrees. And for the valgus knees, it is not that big, but it's also very similar. So if you voluntarily undercorrect your tibia cut in the varus knees, it is leading to a significant undercorrection. So 3 degrees and maybe in 5 or 6 degrees. So that is really the danger. So the consequence of that is, if you want to think about individual alignment philosophies for your patient, then I think you also have to make the next step. That can precisely only be performed with the help of CAS or robotics. Otherwise, you end in a situation like that. Good intentions, bad results. So we have 2 prerequisites for an individual TKA. It's not only the robot that is coming in. I think it also needs a lot of understanding from our side, the surgeon side. What does it mean if I want to place my knee with kinematic alignment in this specific situation? So you need to have some training on that. And for that we developed this computational alignment trainer, the KNCAT system, which simulates typical situations in the OR, and then you can plan and execute that on that app. So the learning is outside the OR in a stress-free environment. I think that's the big advantage. So you come well prepared into the OR, you're able to use your robot, and you know what are my new goals, and then I think you will end in improved medical outcome and simultaneously you're still happy with that. So the tool is a digital training platform for simulated TKA surgery. It is available more than a year meanwhile, and it's based on more than 1,000 data sets we have put in. And we have at the moment 11 alignment workflows and philosophies included, so you can train whatever you want. And so that is something, more information you find on our webpage. So for example, if you perform your tibia cut with mechanical alignment, it is always a zero cut, as you see here, and nothing is changing on your gaps. So that is your medial side, that is your lateral side, and in this typical varus knee, you see the medial extension gap and the medial flexion gap is a lot larger than the lateral one. If you place that cut in patient-specific alignment, so based on the individual anatomy of the tibia, that knee needed 4 degrees of varus, and you see that most of the release is almost done by placing my tibia in 4 degrees of varus on the extension side and on the flexion side. So you just take out the osteophyte and that's it. But the consequence is you leave that knee in 3 to 5 degrees of varus in the end. So the good thing is this simulation tool helps you to reduce the learning curve. And as you have done that before you go into the theater, you have less stress in the OR, and it increases the acceptance also from the team for the robotic system that is introduced in your center. But we still have open questions. So what is the perfect knee? Is her knee the perfect knee, or is his knee the perfect knee? And if a patient like her comes to you, what is my goal? Shall I aim it for her knee or for his knee, or something more individual? And if we have patients like that with constitutional varus or constitutional valgus, how much should we correct? How much can we leave? So that is, I think, not answered, and we have to find the answers. And that is probably the greatest benefit of all these digital tools. You really have quantitative data. So that's the big difference compared to conventional surgery, where everything relies on the experience and of the surgeon and the impression that he has on that knee. So there is more qualitative data, but with the new digital tools you have quantitative data, and that quantitative data then can be used for further analysis. So that is, I think, the future, that you connect all the different data that we have. So all of us, I think we take patient-specific data pre-op, we measure scores and angles, and we take a lot of parameters intra-op. And then post-op, if you see the patient again you collect a lot of data. And if you bring all that data into one platform, and then with the help of machine learning and artificial intelligence, hopefully one day we have the situation that we have some support telling us, okay, that knee maybe is a good one for mechanical alignment, that knee maybe is a better one for kinematic alignment, and that knee is maybe one you should not treat. So this is hopefully the future, that we get more support from the technical side that is helpful for us. So it will not perform the surgery for us, that is for sure. We are still in the lead, but it's giving us some support. So to conclude, it's since 25 years or 30 years, we're on a long road. And a lot of steep curves and all that were on that road already. But we have a lot of miles to go and challenges ahead. But I think it is the only way to solve the existing problems. So to summarize, CAS and robotics are the only options to perform individual TKA surgery precisely. So if you think about more individual approaches, then there is no way without. And if you want to implement CAS or robotics, that is challenging for the entire team because the entire workflow needs to be changed. And that is a challenge, as I said, for the entire team. And you as the chief surgeon, you are the moderator, and that is quite challenging sometimes. Additionally, we all have a long learning curve on that. We can make digital mistakes because we don't understand the numbers correctly. It takes time in the beginning, and a big problem is costs. Learning tools like I've shown you, NECAT for example, are important, I think, to minimize the learning curve in the OR and to reduce stress and improve the results. And the investment costs and the daily costs are the problematic part as long as CAS and robotic is not accepted as the scientific new gold standard. And if they are, then of course you can charge the insurance company or someone else for the extra cost. At the moment, at least in Europe, we're not allowed to do that. So it's just adding cost to the DRG. Thank you.
Thank you, Professor Graichen. Thank you for having joined us from Germany and taking your time and attending this.
It was my pleasure.
Attending this conference. It's our pleasure also. Thank you so much. Any questions?
You have any questions?
Any questions from the floor? There's a question from Dr. Rajkumar.
Dr. Graichen, that was a very good, extensive and elaborative talk on the technology. I have a couple of questions. The first question is, do you always do your TKRs by navigation? There is a CAS.
I don't know if I understand the question, so the sound is pretty bad. So the question was, do I do my navigation in all the cases? Is that right?
Yep.
Yeah, I do it. So my decision was, I think, meanwhile, 15 years back, that I was convinced of the system, so I use it in all my cases.
Okay. So with you showed so many alignments. Like I know there is a lot of buzz about constitutional, kinematic, functional, patient specific, but with the navigation or the robotic, which alignment are you following?
Yeah, so I moved from mechanical alignment to adjusted mechanical alignment, I would say 6 years back. And meanwhile, 1 year of experience with patient-specific alignment. So that's the technique where you place your tibia in the individual anatomy with a limit of 4 degrees of varus. And then it's a gap-balanced femur on top of that.
Okay, and also you mentioned about the tibial cut according to the patient specific, but the tibial cut. Can you hear me?
No, the sound was not so good. Please repeat it again.
No, the tibial cut which you mentioned, like specific to the patient, and if I'm correct, actually that is not accepted. Like you cannot cut the tibia in varus or a valgus based on the patient's alignment. So it has to be 90 degrees to your mechanical axis, but the soft tissue balancing has to be patient specific. Is that the two different things? How do you do?
No, it's a good point. So what we want to achieve is, of course, the natural ligament balance. That is true. So therefore, it is very important to take out all the osteophytes. But with the new alignment philosophies, you don't want to work that much on your ligaments. So that means you compensate for the difference in the gaps after you have taken out the osteophytes by the implant position. So that is more or less the summary what all the patient-specific alignment philosophies do. But I think it is very important, and especially in a country like yours, India, you have a lot of deformities. also extra-articular. So, and the reconstruction of patient-specific anatomy is intra-articular. So if there is a deformity extra-articular of maybe, I don't know, 15 degrees extra-articular varus, that is something you have to take into account, and then I think you have to do a mechanical alignment if you want to correct that.
Yep. Thank you.
Thank you. Any other questions? Yes, Professor Sugavanam. Another question, sir.
Good afternoon, Dr. Graichen.
Good afternoon.
With your rich experience with the navigation, is it only for the cuts and the alignment, or you are interpreting the data after the implant positioning also?
I think a lot of studies have shown if you use it just for your cuts, so some surgeons just use it for their tibia cut and their distal femoral cut to correct alignment and to be sure about that. That is not really beneficial. So I'm really convinced that we also should use the data from the gap size. So that gives me the information of the imbalance or laxity of a joint. And of course, I use that part, and I think it's even more important than my bony cuts.
Is there any scientific developments happening, dictating these data, dictating onto the future designs of the implants?
Just understood the beginning of your question. Scientific data on what?
These data, what you get in the alignment, are you pushing it towards the implant design? Do you have a choice of a particular implant design much better suiting your alignment cuts after using the robotic bone cuts?
I think that's a very important point you made. So if we change our philosophy and change it away from a zero cut, the great majorities of implants are not tested for that. So it's a kind of an off-label use that a lot of surgeons are doing at the moment in Europe and in the US. So the only implant I'm aware of that is tested for 5 degrees of varus is a tune. So this is what they have done. And I think it is important to test the implant, because if you place that joint line oblique and leave the knee in varus, there are a lot higher forces on the implant. So longevity can be the problem. So that needs to be tested, I think, and this is what is done for a tune. But for example, for other implants, it is not.
Thank you.
Thank you. Any questions? Yeah. So nice of you, sir.
Professor Graichen, I'm Dr. Sivakumar. I think you have come a decade before to the same hospital which was functioning in the previous premises in Madurai, and we had a live demo. Unfortunately, the navigation system did not work. So it was a simple primary case, but we were not able to proceed for that case since the navigation did not work. And we got the point today that whether it is difficult or easy, you have to stick on to the navigation system or the robotics which you are preferring, and it has to be a long learning process. Dr. Graichen, you remember 12 years before?
I really could not understand you. Okay. The sound was pretty bad.
Okay. Right. Anyhow, the audience here got it that the long learning curve is required for the navigation or robotic assisted surgeries. And all the cases should be taken for that matter, whether it's time consuming or not. The audience got the point.
The audience could understand your point. That's what Professor Sivakumar says. And we all got it. And it's very nice of you, Graichen, for having...
Thank you, Professor.
And thank you so much for joining us. And you rightly said about the cost. The cost is so much, even in Germany. In India, it will be very much more, unless the insurance company, as you said, will take it as a new gold standard. Otherwise, it's difficult to go on. and definitely a day will come, the future will have more robotics. Thank you once again. Thank you, sir. Thank you.
It was my pleasure.
The audience
Thank
really
you.
appreciates and claps. Thank you, sir. Thank you. Next, we will go on to the next topic. Will be Dr. V. Somasagar, Arthroplasty surgeon from Preethi, will be talking on bone defects and role of stem in primary TKR. Over to you, Somasagar.
Thank you. And at the outset, I'd like to welcome you all for this CME. Thank you, one and all. It's my pleasure to see all the giants under one roof, because I know Dr. Rajkumar sir, Sugavanam sir, Rajesh, Rajesh Malhotra sir. So we are very honored and fortunate to have you all. Coming to the topic per se, management of bone defects during primary total knee replacement. We all know that depending upon the varus or a valgus knee, the defect will be posteromedial or medial in varus, and it will be central in valgus knees. And how to manage them, and what is the reasons why we have defects is that we all know that our patients come very late during the natural course of arthritis, and by the time they come here they have very pretty bad knees, and the reason we have found is that they have either osteonecrosis or a previous trauma or a cyst and osteotomies. This lead on to either collapse or subchondral sclerosis. And how to classify those bone defects, this is the RAND classification into 4 grades, 5 to 10, less than, more than 10, and it should not be confused with AORI. This is for basically revision knee. How to manage these defects? There are variety of ways by which you can fill these defects. We'll go by each type. The most simplest thing is do a reduction osteotomy, and the next is, if the defect is between 5 to 10 mm, you can put a screw and then fill it up with cement, and then either you can use the posterior condyle of the femur and then use screws and reconstruct it. That's what we were doing it. Now these days we are adding a small stem for that as well, and if you have the affordability to use, then you can use wedges as well. Let's go with the examples. Small defects, probably with your cuts and reduction osteotomy, you'll be able to get away with that. When it's between RAN 2 screws and bone cement, you do your regular cuts, fill those defects with 1 or 2 screws and fill it with cement, and then you can get away with results, something like that. And we also published these results long back, and we were able to get reasonably good result. But one point of context we had this is that do not use screws in severely osteoporotic bone, because they will collapse terribly for a period of time. And then we switched on to screws and autograft. There are certain tricks. Make sure that it's a very big defect and you have a very sclerotic bone. Don't try to put a graft on the sclerotic bone. It will not. It will get absorbed over a period of time. You need to prepare the bed properly. Make sure you have a very good bleeding bed. Use the posterior condyle of the femur, distal femur cut, and place it in such a manner that you remove all the cartilage on the surface. Otherwise, if you put on the cartilaginous surface onto it, it will not integrate. So a good bleeding bled, and at the same time you should have a raw surface, and you should achieve compression. People try to put transfer screws, it is not going to work. And this is how, this is a technique as usual. Put some KYs and then add screws. And before you put a final implantation, keep your tray and try to see it. Make sure that screw doesn't touch the tray, because otherwise you'll end up in having fretting corrosion over a period of time. And again, these days we started adding one more stem, because probably you need to unload it for some time so that it is going to integrate properly. Yes, if you have the resources and the affordability issues is not a problem, then you can add wedges as well. To summarize, small defects, you can have lateralization and do a reduction osteotomy, and if you have between 5 and 10, you can get away with cement and screws. More than 10, autograft with stem. And defects with ligament instability, probably you have to go with semi-constrained or constrained implants as well. Coming to the second part of my talk, role of stems in primary TKR. As usual, as earlier I told, it can be used in defects, intra-articular and extra-articular deformity correction, stress fractures, metaphyseal, And obesity, a bit controversial, we'll come to that later. When there is a pre-existing stress fracture in this kind, you need to unload it, you need to allow it to heal. So you add a stem and then you get away with that. And you have a deformity with an implant in situ, you need to support that weaker bone. Then again you can add a stem there. And then your TKR is part of a deformity correction as well, and you are not sure about that union in the distal femur, then you need to bypass it. Yes, I am pretty sure that the size of the stem is a bit low. We agree that. And this is again another this study which we are doing for the last 4 years. What happens if you do a total knee replacement with a short keel in a patient with 106 and height of 160 and a BMI of 42? Probably, if you have not done your job rightly, probably you may have a varus collapse as well. So what we did was functional and radiological study, and we choose patients of obesity class 2 and 3. And in obese patients, we all know that there is excessive joint loading, and it results in ONE much earlier in their life. So there were 34 knees in 31 patients. So it was standard approach. And if there are small defects, we added screws. If it's long, then we added autograft. But in those cases, we added a longer stem. In regular patients, what we did was we added a small stem, 30 mm into 13. So this is, and we cemented the whole stem. And this is what we were able to get away with that for a period of time. This is our patient. Sorry. Okay. Next slide. Yes, this is the alignment. Regarding intentional varus, we'll come to the discussion part in the debate to do an intentional varus in bilateral total knee replacements. These are patients, and it's okay. Okay, we can get away. To conclude, so probably IBMA patients, a small stem cemented one plays a role in future in reducing the risk of early failure due to aseptic loosening, and probably it may prevent early revision procedure. We have to wait and watch because this is a short study of just 4 to 5 years in the maturity down the line, and the number of cases are also pretty less. And probably this is what made us feel that we need to add stem in obese patients, improved fixation, reduced micromotion, and stress shielding and preventing collapse. And again, I take this opportunity to invite you all upon for another course next month, a course on July 24th. Thank you.
Thank you, Dr. Somsekhar. It was a crisp talk on how to manage bone defects and role of stems in primary TK. It was good. Do you take the thickness of the polyethylene as one indicator for using a stem?
No, sir. We don't. There's obviously what for us, what we feel is that if you are using a poly of more than 15 or something, that means that you have not balanced it right. Normally, that's one thing. And one more thing is that we use this small stems only in very obese patients, 35 and above. First we did 40 and above. Now we are decreased it because we wanted to see how they fare over a period of time. But poly per se as an indicator to use a stem, no. We haven't done anything like that in our patients.
Any questions from the floor?
Your opinion on case with complex fractures with osteoarthritis, what to go with a stem or how to proceed? Any role for it?
Yes, if you are able to get away, means if you are extra articular deformities, you are able to correct it through your knee replacement, then you can get away with that. But if you have a very big defect, in those kind of situations, you do an extra articular corrective osteotomy and then use a neutralization plate or something like that, and then you bypass and try to put a stem. That is what. In those cases also you can use stem, but make sure you don't use cemented stem. You should use an uncemented stem. This small stem is only for obese class of patients primarily, whereas in revision or in complexness it is pretty understood that you need to use some form of stem so that the load bearing or load sharing is transferred more onto the diaphysis.
In primary trauma, sir, if it's a simple condylar fractures?
Central condyle, again that's again another interesting one, doing trauma and the total knee replacement. I think that we haven't done much cases, probably Rajesh, Malhotra, sir, or someone. In primary fractures, doing total knee replacement and then doing any stems or something like that.
That's a very good question. I'm giving a talk on 3rd of July in Delhi, in the Delhi Orthopedic Association meeting. I often call it emergency arthroplasty like you do for a fractured neck of femur. So if you have an old osteoarthritic patient and she sustains a periarticular fracture, it's pointless to fix it for many reasons. One, she'll not be able to put weight on it because till the time the fracture has healed. Second, you will put in a hardware which will make it difficult for the subsequent knee replacement to be done. Thirdly, you saw an example where the implant was removed. He showed an example of hardware when there was an indication for stem. So all hardware was removed and a stem was put in. Sometimes we just leave the implant inside and take out a few screws and put the normal knee in order to avoid prolonged surgery. But then we know that if you put implant, subsequent surgery becomes difficult. Also, in the knee replacement, the rates of infection are much higher in a previously operated knee if you do a knee replacement compared to a primary. So with these many reasons, I would just have no hesitation in doing TKR primarily in any patient who has a periarticular fracture, because that's one-time surgery. They are able to put weight immediately, and it doesn't really matter if the fracture doesn't heal also. They are able to carry on because there's a stem which is fixing distally. So yes, there's an indication. And then in a very badly comminuted fracture in a 80 or 90-year-old with comorbidities, I just possibly just could quickly put a distal femoral replacing prosthesis and come out quickly. So there is a room for every procedure in medicine. Just remember that. Never say never. So there will be indications for that.
Yes, yes. But we have to narrow down the indications. Otherwise, all distal femur will be replaced over a period of time. With but again, cost will also add on to it.
You can directly go for knee replacement processes, and either modular or the available sizes are there. You can directly go for replacement instead of wait for the patient, 70-year-old patient with the knee comminuted supracondylar with articular surface involvement. You wait until heal, then with the OA changes. Better directly go for thing, and
okay,
people
so
are doing it.
It's just near to the articular surface, it's fine, but if there is something which is extending all the way to the diaphysis, and then probably that could be a difficult situation.
How much it is extending.
That is again one more point that's to be noted of as well. Sir, is there any experience of doing TKR and adding an accumulation plate as a primary? Means like do you add a plate in those kind of situations as well?
The plates can be used, the plate and stem both can be used. You can have a combination. Usually the stem is the best thing because it helps in the weight transmission. But if you are not happy with the rotational stability, I'll have no hesitation in putting a unicortical plate.
Thank you, sir.
There are no more questions. Thank you, Somshekhar. Now I call upon Dr. Vrajesh to speak on patient satisfaction. Is it still an unsolved issue in TKR?
Thank you, Preethi Hospital, and especially organizing chairperson Professor Sivakumar for inviting me into this gathering. And special thanks for all the hospitality, and I am astonished visiting the Meenakshi temple today, and thank you. Now, I think Professor Graichen has started the ball rolling in line of my talk. One philosophical statement, only constant is change. And arthroplasty is also continuously changing since 50 years, and we saw a lot of alignment options. Why so many options? So still we think there is something unsolved, and we and the future generation need to find solutions to those problems. I represent Vairok Hospital, which is a 50-bedded hospital located in Vadodara, a city about 100 kilometers from Ahmedabad. Goal of ideal total knee arthroplasty is very simple. It is pain-free mobility, practically permanently lasting implant, and a delighted So, what is a acceptable mechanical alignment? In coronal plane, line drawing the center of hip and center of knee, and if we cut the distal femur 90 degree to it, again line joining center of ankle and center of tibia and cutting it to 0, neutral, and overall hip, knee, ankle axis. If it stays within 3 degree of varus and valgus, we call it as a acceptable mechanical alignment. Usual anatomy is not this. We should understand. Our routine anatomy is relatively an oblique joint line with distal femur in 2 to 3 degree valgus, proximal tibia into 2 to 3 degree varus. Again, to compensate that, in coronal plane we are cutting 90-90, the distal femur and proximal tibia. To compensate that, if we cut the posterior condyle equal, we will have a loose lateral gap. To prevent this and getting a rectangular gap, we external So, the goal of mechanical alignment is rectangular space which is equal in flexion and extension and which is equal medial and lateral. We look to survival data. There are multiple studies, meta-analysis, all suggesting a very good survival data of mechanical aligned total knee arthroplasty. This is the second paper. 10 years survivalship, 92 years. More than 90% implant survival at 15 years. So, mechanical alignment is successful for long-term survival of implant. That has been established. Now, we go on the satisfaction side. Now, National Joint Registry, which have studied about more than 8,000 cases, and their overall satisfaction level, Registry of England and Wales, line is medially oblique, pointing downwards. So this is how our actual mechanical axis is in femur and tibia. So by mechanical alignment, we are skewing this mechanical axis. So I introduce simple terms, that is lateral distal femoral angle and medial proximal tibial angle. So lateral distal femoral angle usually is from 85 to 90 degree and medial proximal tibial angle is from 85 to 90 degree. So femur is in valgus and tibia is in varus. Lot of studies of this study was of 4,800 cases in which they found that medial proximal tibial angle of normal knee is 4% cases and lateral distal femoral angle is only in 5% cases it is 0. And hip knee ankle axis and MPTA and LDFA both at 0 is only in 0.1% cases. What about ligament tensions? Medial collateral ligament tightens during flexion, anterior fibers, and posterior fibers tighten during extension. So we can consider it is, as a generalization, it is concentric throughout the range of movement. Lateral collateral ligament tension decreases from extension to flexion, and so we are able to sit cross-legged. Key points is collaterals have highly individually variable, women's are more lax, MCL is routinely tighter than lateral collateral ligament, MCL and LCL are looser in flexion. For practical purpose, MCL and LCL are equally taut in full extension, MCL is isometric throughout the range, and LCL is relatively lax in flexion. So what different we are doing than the normal anatomy in mechanical alignment? We are having a one-size-fit approach in every cases. So we aim everyone at 90-90. Whereas this is not true for most of the patient. I am taking 2 lectures together, so I will complete my talk in 20 minutes. We are changing the joint line orientation. So this is the other change which we are doing in mechanical alignment. We are altering patellofemoral biomechanics. So we are overstuffing the distal lateral femoral condyle, leading to abnormal lateral retinacular stretching. So that what lateral retinacular release we are doing, this we have installed. And this is causing abnormal patellofemoral biomechanics. So, though equal flexion and extension gap is the goal of mechanical alignment, this is not as per our normal anatomy. We introduce actually ligament imbalance by not following the normal, not aiming at the normal anatomy. And from where did 90-degree tibial cut come? So, because we don't have a precise instrument, 3 degree on either side error is possible. So we aim at 90 degree and ultimately we'll end up in 3 degree error on either side. And there was study, even with normal, with this mechanical instrument, 18% knee, we are outside 3 degree. So altering natural anatomy disturbs natural concentricity of ligaments. Balancing of ligament, we do it by releases, and it nowhere comes near knee, normal knee biomechanics. Can this be a reason for dissatisfaction in mechanical aligned knee replacement? And this is the reason why there are so many alignment options now people are thinking of, because we have improved in precision of our instruments by CAS and robotics. I'll talk in brief about this alternative alignment, which was last in the table, kinematic and restricted kinematic alignment. This work, pilot work, is being done by Stephen Howell, and he's a designer of Caligmer kinematic alignment technique for total knee replacement, which is a US FDA approved technique. I'll not go into the detail of this definition, but femur is the leader of joint replacement, and concentricity of medial collateral ligament is on the femur. So if we exactly replace what we cut, considering
Dr. Rajkumar.
Team for inviting me and this excellent program. I'd like to thank and also my regards to Professor Rajesh Malhotra sir and Dr.Sugavanam. Thank you sir. Valgus knee, how to get out of the trouble. Before starting this talk, I would like to say this is totally a non-navigated or a non-robotic talk. So he has given an elaborate, extensive idea about robotics and kinematic alignment. So don't correlate that talk with this talk. This is nothing related to navigation. Okay. So more of a basic talk. How to get out of the trouble. More than that, we'll see whether we can do some justice to the topic. 10 to 15% of the total knee replacement is for a valgus knee, the incidence says. And this kind of deformity, the Windsor deformity, is so common in our part of the world. One side varus and the other side is a valgus deformity. And if you look at this slide here, it's like I've shown here as a then you know that you have to keep your bone cuts very minimal, starting from tibia to distal femur, not only in the distal femur but also in the proximal tibia, just 5 mm, sometimes even 4 mm has to be kept. So get the tibial resection correct. Whether to cut 90 degrees to mechanical axis or not, that is a debatable, but now at present in a valgus knee, manually take it 90 degrees to your mechanical axis. Then the literature also says that always better to reduce the valgus angle, so to always avoid the recurrence of the deformity. So 5 degrees, if you keep it for a valgus angle in a valgus knee, it is better to keep it 3 degrees. The next important slide here is you should not always cut to the damaged part, at the level of the damage. That means you will be taking more on the medial side. So this clue just gives you an idea how much you have to avoid cutting the medial. So you should not cut too much on the medial side. So that means what? You have to reduce your distal femoral cut. Sometimes your blade will not touch on the lateral condyle at all. So don't worry, you should not do that. You should not cut anything on the lateral condyle. So once you do that and then do the release, that too most of the time you will not need a release. So that time you will be able to achieve this kind of extension. So the most important part is the femoral rotation. At present, what are the tools you have? You have the epicondylar axis and your femoral condyle. If your femoral condyle is hypoplastic, you have to be very, very careful. So a hypoplastic femoral condyle, as I mentioned, you have to make sure that you get your rotations correct. See here, so when you get your rotations, you have to make sure you are on line with the epicondylar axis. So once you do that, then make it parallel to your 90 degrees cut of the tibia and get your rotation correct. So when you get your femoral component rotation, many a times you will be managing your femoral flexion gap. So flexion gap is managed with your femoral rotation properly. Then comes the soft tissue balancing. So in a valgus knee, you will not be able to achieve straight away a soft tissue balancing and then do the femoral cut. You have to balance it, like take some cuts, go do the balancing again, if needed, do the proper cuts again. So which one to release first? Lot of debates, lot of protocol saying this way, that way. But if you have to understand, in a valgus knee there are two types. Extension deformity without a concurrent flexion. There will be only a valgus deformity in the extension, not in flexion at all. And then the type 2 is you will have a flexion deformity along with your extension deformity. But most valgus, it occurs during only the knee extension. In flexion, there won't be any deformity at all. There won't be any contracture at all. So you have to understand that. Why? That will help in your release. So in an extension deformity, you have to do some minimal release, like the IT band release from the Gerdius tubercle. You are not cutting the IT band, but you are releasing it in the Gerdius tubercle. And sometimes you can do a pie crusting. That's all is needed. Because in flexion, there is no contracture. Whereas in a flexion, how to balance it? Lateral structures not as tight and medial structures not as lax in flexion. So you have to be very, very careful, and you have to understand that in flexion it is the other way around. So you need to know, and this correction can be done by component placement, your femoral component. So here, see here, just by placing the femoral component correctly, get your rotations, you can be able to manage. But still, if you have a flexion contracture in a valgus knee, then you can do a posterolateral corner release with a laminar spreader like that. So that will help you to correct the rotation, flexion contracture in the valgus knee. So this is an excellent paper, even though it is published in 2005 by Ranawat et al. Very good paper. Most of the time, almost always you can get away with this technique. Posterolateral release and your pie crusting of the ITB. That is all needed. And many a times you will not need your lateral collateral or a popliteus. I never remove my popliteus at all. So very, very rarely performed. So that is how the valgus needs, because remember that 95% of the time it is grade 1 or 2, only 5% it is grade 3. And then coming to the patellofemoral, yes, many a times the patella is suplex or laterally pulled. So you will need a lateral collateral ligament, lateral retinacular release after your placement of your implants. Don't hesitate to do a lateral retinacular release if it is needed for a better tracking of the patella. So here I have resurfaced only in selected cases. Coming to peroneal palsy, always we think that a valgus knee will produce a peroneal palsy, high chances. No. Why? You have to keep your insert size as minimal as possible. If you get your cuts correct, your soft tissue rotation, femoral component rotation correct, then that means you will need a very, very minimal insert like an 8 or a 10. That will be the maximum. Very, very rarely you will require a 12.5 or a 15 mm. So if you get your insert thickness small, your chances of peroneal palsy is almost nil. But in spite of that, if you get it, next day if you see,
Then immediately keep the knee in little flexion, avoid any movements, and also loosen the bandage. In a day or two it should recover. So that is the most important thing, and you can avoid it many a times. So in total knee replacement in a valgus deformity, is it still a challenge in 2021? No, not at all. Because there is no definitive evidence which is the correct way of release, because now not needed at all, not much of release is needed. That is what in 2022 we know. So the trend is do a very minimal release. No need of any big release. If you do a big release, later on, post-operatively, you will get instability. 5 years later, 6 years later, we don't know. Higher instability, loosening and reoperation. So just few quick examples. Grade 1, this lady, if you look at this, it's a simple valgus knee. Go take the stress X-ray. You know that it is a correctable, and post-operatively you can achieve this kind of a result. No need of any big release at all. One more X-ray, but Windsor deformity, very very common. We all should understand that Windsor deformity is very common here. You have to get your balancing correct, and you will be able to get a good post-operative movement. Valgus knee in a grade 2. See, 76-7-year-old female rheumatoid. Look at the deformity here. Look at the bone loss in the lateral femoral condyle. It's very scary. We might think that we will need a very big constraint processes at all. With the stress view, we know that what we are dealing with. We are dealing with bone loss. Predominantly, the valgus deformity is due to the bone loss and not due to the soft tissue here. See here, correctable valgus. So stress view gives us the idea. What are the options? The option here, what you have to get your basics correct. Minimal cut in the tibia, get your rotations in the femur, and then manage your bone loss in the tibia, which is a contained defect. Once only screw is needed, and with the proper cementing, then you will be able to manage it with the primary simple PS implant here. No need of any constraint at all. But on the contrary, if it is a grade 2, partially correctable, sometimes in a rheumatoid, where the medial side will be like a very very thin MCL, just attaching it will peel off without even doing any manipulation. Those kind of cases, where the MCL is stretched, you will need a constraint, like a TC3 process like that. So this lady, 16 years on the right side and 7 years on the left side, she is walking well in a rheumatoid knee. She is a grade 2. Coming to the grade 3, look at this female, 76-year-old female, Windsor deformity, grossly osteoporotic, old age, osteoporotic, gross valgus. This is the deformity. But the most important thing here is old age, valgus, osteoporosis combined with the hyperextension, gross hyperextension, hypermobile knees. These are all very very notorious ones. So here you cannot think of having a small constraint PS implant or a TC3 like thing. You will better to do, even though it is a correctable valgus, it is better to go with a constraint process like a hinged, rotating hinge. What are the indications? Old age, osteoporotic, gross valgus, gross hyperextension and instability. So old age particularly. So you have to give a one solution, one surgery for this lady. So hinged is a better one. Even though this lady is a 58-year-old windswept, again a right side valgus, see here the hyperextension. Always remember a gross hyperextension. Once again, this example I put here because even though she is 58, whatever the age might be, if it is a gross hyperextension with a valgus knee, a hinged rotating implant is a very very good implant. Particularly an implant like this with a metaphyseal sleeve, which you can use it in osteoporotic cases. So role of hinges, yes, collateral ligament insufficiency, hyperlaxity, osteoporosis, gross valgus, hinged knee is a very good implant. So take home message, 95% of the time you will not require a very very big release or a constrained knee. You can manage with a CR or a PS, that I leave it to the surgeon's skill. A regular PS knee will be enough, and occasionally a TC3 or a CCK type of constraint process is needed. And sometimes in osteoporotic bone loss or hyperextension deformity, rotating hinge process should be considered. Thank you.
Thank you, Rajkumar. Wonderful talk. And your talk should be encouraging to the youngsters who would have thought that valgus knee is very difficult to operate. And you have given a lot of practical tips. And I have a doubt. Do you routinely do pipe testing?
Not really. Not really. Very, very rarely. In fact, I try to do this ITP release from the Kurdish tubercle whenever is needed. And then I do the posterolateral complex release whenever there is a flexion contracture in the pelvis. So not for routine. Very tight, yes, like in a grade 2, if it is partially correctable and if it needs, okay, but not.
Valgus with hyperextension and valgus with the FFP. How does your stuff
Same thing. Valgus. The only thing is the valgus with the gross hyperextension. You, as I told you, you cannot be very casual with the valgus with hyperextension because post-operatively also it stretches a lot. That is the most important. In FFT, you will see rheumatoid. Valgus with the FFT, rheumatoids you will see. But osteoarthritis, valgus, hyperextension, it is a very bad combination. Post-operatively, you cannot expect it to be stable. Even on table, it will be stable. You might think, okay, it is good, but post-operatively, within 1 year, it will stretch out so badly. So that is where I said, in these kind of situations, particularly after anesthesia, you will see still more it is hyperextending. So better a hinged processes. No, that's why my first aim is not to stuff the joint in a valgus knee. That is where you get your complications. So more 99.99% of the time, my maximum insert size is 10 in a valgus knee. So that is why keep your bone cuts as minimal as possible. Keep your release also as minimal as possible. Get your component rotation proper. 99% of the time you can get that.
Keep your cuts as minimal as possible.
And also I don't go by always correct, get the extension correct completely and then go and address the that is theoretically yes it is okay but practically it is not. So I in between like go, come back, go and then balance.
Nice also, thank you. So one conference we came for the younger course, you demonstrated epicondyle advancement for Rajesh.
That is lateral, but very rarely it performs that. Most of the time it is not needed. But yes, if you don't want to like in a grade 2 partially fixed valgus, you can, but very long term results, it has got its own risks also. Your fixation has to be correct, you don't know how much your weight bearing cannot be started immediately, range of motion is delayed. So those things are also there. But if you are really skilled enough to do that, yes, you can. But you can get away without doing that.
So we have seen a lot of videos of middle advancement.
Lateral.
Thank you.
If there are no questions, we come to the end of the session. I thank the Preethi hospitals of the organizing team for inviting me to give this session. For the session with rich of experience and knowledge, especially for the youngsters. Thank you very much.
Now I request Professor Yanchidavaram to honor Dr. Satyanarayana by presenting the award. Thank you, sir. We'll move on to the next session. I welcome Dr. G.M. Rajkumar and Professor Meenakshi Sundaram to chair the session.
Good afternoon, everybody. Thank you, Team Preethi, for offering us this chair. proceed with the second session on advanced arthroplasty, the role of robotics. Since we have, so the first talk will be by Professor Rajesh Malhotra sir on why are knees failing today, an Indian perspective.
Thank you, respected chairpersons. Good afternoon to you. I want to thank Dr. Sugavanam for giving me the opportunity and guiding the invitation. So I'm going to talk about two topics back to back before I go to the theatre. So I'm going to talk about why the knees are failing. So the goals of TPR are clear. They have been reiterated many times. We want to restore mechanical access, have equal flexion extension gap. We want to have ligament balance, and we want to have a full factor tracking. So with those things in mind, still we are going to have a higher number of revisions, which are going to parallel the greater number of primary being done increasingly, and that's going to be the great burden economically. And this is the book on revision knee replacement, where Why Knee Fails was written by the legendary Dr. Larry Dodd. And I'm going to touch upon some of the points laid out here. So they have a significant financial and economical burden. In this paper by Ferring, 64% failures were reported within 5 years, out of which the 38% were infection and the rest were instability. In this landmark paper by Shah in 2002, it was reported that 56% failure rate at 2 years. Instability was the commonest cause, followed by malalignment, and 1/3 of these were totally preventable. Then what happened subsequently was that the Sharkey revisited the causes of failure again after 10 years to see what has changed. And what he found was that in 10 years, the causes of failure had changed considerably. Now, the commonest cause in less than 2 years was infection, and the aseptic loosening was the commonest cause of revision. So in 2003, this was basically the polywear which was the leading cause. By 2013, it was only 10% of all revisions because of the improved polyclean. So that is what made a difference to the cause of failure. So now, most papers agree that the most common cause of failure is infection within the first 2 years, and the factors like increasing age, post-traumatic etiology, and drug abuse are the factors which contribute to that. Although regional differences are seen, but infection and aseptic loosening remain the most common causes of revision. And again, this paper from India showed that the infection is the most common cause, and they followed it for 5 years. Now, in this seminal paper by Kelly Wynn, he said there are 9 causes of failure of the knee replacement. And these are those 9 causes: infection, extension lag, stiffness, tibiofibular femoral instability, fractures, loosening of the components, patellar instability and malrotation, breakage of implants, pain and without any diagnosis, and the last one which we have added to that is the metal allergy. Now, the failure mechanism, if you look at these 6 causes, contributes to more than 90% of the primary knee failure. So, aseptic loosening, instability, infection, polywear, arthroplasty, and malalignment. Now, what happens with polyclean wear is their particles give rise to synovitis, which gives rise to osteolysis, and nearly half of late failures occur because of the polyclean wear. And almost 12% of the early failures occur because of polyclean wear, which arises from instability and malalignment. These things are all interrelated. Now, this is a normal knee you see, and then the adhesive wear in the middle and the fatigue failure in the right. So this is a combination of the malposition and the fatigue wear. It has been said earlier, rotating platform failed to do anything to reduce the incidence of failure because it doesn't reduce the stresses, and we must distinguish between the polyclean wear and the aseptic loosening, which is the progressive loosening of the implant seen with serial radiograph. Now, component loosening is the reason for 17% of the early revisions, mostly seen in uncemented components. And if you do only surface cementing, do not cement the key, and then of course the instability remains an important cause for early revision and implant loosening. It contributes to 1 out of 3 in the late revision, and there the malalignment of components is the most likely reason. So it has been discussed that the component malalignment can be because of faulty surgical technique. It can be improved by computer-assisted navigation or precision instrumentation. For example, this is an example of the gross tibial malposition of the tibial component here in severe valgus. But then, as has been said earlier, that even the computer-assisted surgery improves alignment but does not change the outcome. Patellar complications are a very important cause, and you can have patellar maltracking, patellar baha, it could be post-pedalectomy. There can be avascular necrosis patellar. In the lateral review you heard, it was said that the lateral genicular artery should be protected. That's because we want to prevent the avascular necrosis of the patellar. And then these avascular necrosis is more common with the resurfacing. And then, of course, if you do not resurface the patellar and do a secondary revision, the patients do remain unsatisfied. A very important cause of failure is patellar malalignment, which actually is because of the malposition of your femoral and tibial components, which can be established by the CT scan. In the bottom left figure is an example of the malrotation, the gross internal rotation of tibial component compared to the tibial gross tibial. The top right shows how it should be. So the patellar clump syndrome is becoming less and less common, but was very common with the PS knees and with the patellar unfriendly designs of the femoral component. And then, of course, if you don't remove the osteophytes, superior patellar osteophytes, or don't do the superior post-synovectomy, and you have a PS design or a patellar unfriendly design, you can have this, and then you have to excise it. If you want to prevent it, you will see it in the demonstration surgery also today. They remove the patellar osteophytes and do the superior post-synovectomy. Extensor mechanism failure again is a very disastrous complication. We have published in Journal of Arthroplasty now on the technique, and then this is actually a patient who was rheumatoid, and I want to tell you that the rheumatoid are highly prone to these, particularly the quadriceps tendon repair. And the patellar tendon rupture you can manage, but the quadriceps tendon rupture is very, very resistant to repair, and it's something to really dread about. So this is an example where there was a patellar tendon tear. The patient came to us, and then we used this semi-tenuous tendon and used it around a drill hole to the patellar, and then fixed it. This is the schematic presentation of the same technique. There can be structural failure of the implant. We know that, particularly the PS design, it has been shown that the post-wear or the post-breakage can occur. Arthroplasty is another troublesome complication which can have multifactorial origins, starting right from the complex surgery to the component malrotation to the stiff knee preoperatively, and these are the causes which need extensive investigation and treatment for the patient. Post-tubercular knee which underwent the medial pivot knee, he had a correct component rotation that was put out as a cause of stiffness. We did a complete scar excision along with reducing the thickness of the poly, and this is the flexion he could get after the surgery. Instability is another cause, and that it can be prevented by a proper alignment of the components, proper appropriate tension in the soft tissue, and appropriate surgical technique. And there can be instability can be multifactorial, and that is more commonly seen in the younger and the female patients. It can be flexion instability, genu recurvatum, or the extension instability. The patient can present with a sense of instability, giving way, difficulty in negotiating stairs, recurrent knee swelling, anterior knee pain. The broad test may be positive, and then varus valgus stability may be demonstrable in various degrees of flexion. And if you make the patient sit and pull at the tibia, pull it down, and leave it, you can feel it going back. Another test given by Bob Booth is that you let the patient sit on the edge of the bed, hanging the leg down, and do a tap on the hammer on the patellar tendon, and you will see this, the sudden movement which occurs will demonstrate the instability which occurs in that. This is the obvious posterior sash showing the instability. Notching is another factor which can give rise to periprosthetic fracture and has to be avoided. All of us do that to make sure that when we suddenly rotate the component, we do not end up notching the anterolateral cortex. Fractures occur intraoperatively because of poor bone, poor technique, or poor instrumentation, but the bone can cause it post-operatively also. The principles are the same. You have to span the whole bone. You don't lean stress either. So you have to go all the way to the subtrochanteric region. And this is an example where there was a stem, and the same was treated with the plate, spanning plate, and this was a CRB treated by a leg. Periprosthetic joint infection gave rise to 25% of the early revisions and 8% of late revisions. The less than 1% high volume center, but then you have to be very careful with these. This is the early wound infection with nasals. This is the late infection of the TK. This is an example of the patient had the spacer, and then when you go back there, you have to handle the bone defects, and of course you have to choose the right constraint. But sometimes, like this 73-year-old lady who had PGI because of tuberculosis, multiple failed attempts, and she had a deformity, dislocated spacers, and there was no option to a 73-year-old diabetic with these kind of things but to offer amputation. So that can be the really extreme form of failure. Antibiotic cement is of no good, no use. It has been shown that it does not reduce the incidence of infection, so that is not particularly useful. Do not operate if you don't have a reason for failure. The mystery knee, never touch a patient for revision, never take up for revision if you don't know what was the cause of the failure. The last cause is the metal allergy. We have some experience because we have been the center in the country which has been diagnosing metal allergy. This was a lady who underwent PCR. All was well for a couple of years, and she started having catastrophic failure. And I always say that if an infection is not an infection, it is metal allergy. So this was the Ki67 antigen expression on the T cells, which was the confirmatory thing, and this was the histopathology. Intraoperatively, she was revised with a gold revision system. So to conclude, TKR is not mere an exercise in bone carpentry. You have improvements have occurred in understanding of knee kinematic, method of fixation, and proper ligamental balancing. Sterile technique and precise surgical technique of component fixation is important. Improved polyethylene or alternate bearing surfaces are the future, and you must concentrate on preventable causes, and navigation comes to the assistance. Most of the major causes are preventable. Remember that we talk about patient dissatisfaction because of geriatrics, but not failure. Failure has to be handled by the surgeon as far as prevention is concerned, and the good technique is the key. So with these messages, you remember there is no substitute for a flawless technique, and I would like to invite you to the current concepts in arthroplasty in October this year. My colleague, assistant professor with me, Dr. Sahil, has got some brochures. We go on to the next talk now, which is about the principles of the revision knee replacement. So you have seen some pictures of the book. So I'll try to summarize the 600 pages of the book in 10 minutes. But I think the important thing is to tell you about the principles, and that's what needs to be understood. So go to the slideshow. So how to proceed for a case of revision TK? First, establish the diagnosis. I ended my last talk there. I'll begin the next one here. Do not touch the patient if you don't have the cause for the failure. And of course, like I said, the pre-operative planning is what starts it all. And before you take the leap, you must make sure that you know the cause. Rule out infection in all cases. Screen with serological marker, aspirate, do whatever is required, and use imaging to your advantage to look for osteolysis, component malrotation, infection. You may need MARS, CT scan, bone scan, or PET scan. These are the 5 principles of management: pre-operative assessment, surgical approach, safe component removal, reconstruction, and outcome. To start the pre-operative assessment with detailed history of complaint, look for systemic illnesses, comorbidities, drugs. If a draining sinus is present, that is almost confirmatory of infection, and that should be taken care of in the first stage. The knee examination is something. So you look for the active and passive range of motion, look for the extension lag, and look for the mobility of the backline knee, coronal plate. This is just a video showing the instability, the examination of that. And then if you have Patel, you will have difficulty in exposure and dislocation. So that is the instability. And then of course you have to assess for infection with the correct definition of that. But you must find out if in case of infection what is the bug, because it makes all the difference. And we have this sonicator. Anything which comes out of patient's body in terms of implant or metal is sonicated. And we have actually published and shown that the sonication of the orthopedic implant is actually much more sensitive compared to the periprosthetic tissue culture. Although both of them have the same degree of sensitivity. So nothing which comes out of patient's body is not subjected to sonication. We are able to prepare to get the diagnosis. Also, we use the 16 rRNA for the diagnosis, and that has helped us diagnose some very unusual infections. For example, we could diagnose the Lysopecta thermophilus as a cause for infection, Salmonella typhimurium infection. We actually diagnosed a prosthetic joint infection, muscular xenoseptia, and this was an E4B paper on the spectrum of infection in periprosthetic joints in the tertiary care center, and the antibiotic stewardship was the special mention award. Remember that some of the bugs are more amenable to make or efficient at making the biofilm, so it is coagulase negative staph and the enterococcus, which are actually the worst one, and we should be wary of them. Then of course, this is a study we published where we looked at the capacity of different bugs to form biofilm on different kind of materials, and we found that polyethylene was the most amenable to or susceptible to biofilm formation. Hence, we need to replace the insert. So you take in the debridement and implant retention, you remove poly not only to wash the tray, because there would be some fluid and infected material between the insert and the tray, but also there would be in all likelihood a biofilm on the polyethylene which sets in very quickly. And of course the bugs influence the outcome of your treatment. So Pseudomonas equine is associated with more inflammatory response. If I find Klebsiella, I am very worried because there is a higher mortality with Klebsiella. So if it's an old morbid patient, I will not reimplant sometimes if I find Klebsiella, because I know that these diseases are very difficult to eradicate and they can actually kill. And if you have the MRSA with a high risk of reinfection and increasing operative time. If you have fungal infection, the cure rate is only 38.5%. And then if you have the viral hepatitis, again, the risk of reinfection is very high. So if you have the bug, you know whether your debridement will work or not. And for example, it's inefficient for MRSA, it is moderately successful for methylene susceptible staph aureus, and it's a valid option for streptococcus. So it's very important to know your bug. That's why I spent some time on this. Again, if you have organisms like resistant, atypical, or culture negative periprosthetic joint infection, the failure of the reconstruction is much higher. So remember, Klebsiella, Pseudomonas, MRSA, Enterococci, mycobacteria, and fungi are much more likely to lead to a failed remission. This was a patient who came to me operated by my friend in the city. He operated in an 85-year-old bilateral knee. Both sides got infected. Both sides inserts were put in, and he was not walking. Looking at his age, I debrided the worst side and put him on a laser rope, and debrided the other side and put in a spacer, and then went on to put in a hinge on the other side. He successfully treated and walking around. This was an infection because of non-tubercular mycobacteria. So this, of course, was published, but then to tell you that with times now we are getting the unusual infections, and you must keep them in mind. Then, of course, the pre-operative assessment must include the radiograph, looking at the posterior osteophyte, heterotopic bone, location of the petala, which will give you an idea about the exposure. It will also give you an idea about the zonal fixation. We know that there are 3 zones of fixation, and the zone 1, which is actually the articular surface, is often compromised. So you have to actually rely on fixation on the zone 2 and zone 3. You must have fixation at least in 2 zones, and in this kind of example where the metal layer had to be removed, we have to rely on the 2 zones of fixation. The surgical approach is extremely important. This is extremely critical to the success and then you must minimize the problem by proper selection of skin incision, vascular anatomy, patient risk factor, and operative technique. And so if this is the vascular anastomosis around the knee, if there are many scars, you should take the most lateral scar as been told. And if the skin is non-pliable, you must actually give a sham incision and see whether it heals before going in for definitive surgery and operating. And you may have to take the help of plastic surgeon or the flaps or the tissue expanders. Now, challenges in exposures can be because of the non-pliant skin, which can be if the patient has been chronically in pain, or if there has been biological response like infection or particulate debris, or if there has been instability. Medial parapatellar is the workhorse, but you can actually do a rectus snip to improve the outcome. But during exposure, you must deprive the synovial recesses and remove the adhesions. Removing the adherent tissues will help you in getting the motion also. Must dissect the joint capsule if required. You must skeletonize the distal femur. If the patellar displacement is difficult, don't be in a hurry to invert the patella. Put a pin in the patellar tendon insertion so that you don't avulse it, and then debride and be very patient. If the flexion is less than 90 degrees, the extensor mechanism is really at a high risk. Patellar tendon is the weak point. Make sure that you don't end up rupturing it, and use one of the methods to de-tether the extensor mechanism. And this is the femoral P. I said you should not hesitate to skeletonize the distal femur in a very stiff knee. Medial apicular osteotomy has been described as a way to increase the exposure. Safe component removal depends on the optimal technique, optimal tools, adequate exposure, and the patient. So that is you don't want to remove too much of bone. You can use the wiggly saw, or you can use the step. Osteotomes are not a good choice. They end up crushing the bone, so I don't use it particularly. But what I do use is the reciprocating saw or the wiggly saw, and then they can be used gradually. I always start by taking off the polyethylene, and some people will tell you that after removing that, remove the femoral component. I don't normally do that because in order to deliver the tibia forward, if you have removed the femoral component, your retractors will crush the femoral bone. So even if the femoral component is loose, I just put it back and then lever the retractors against it to deliver the tibia forward after doing a complete release of the posterior medial corner in order to make sure that the femoral bone is preserved. And then, of course, you can, on both sides, you can actually disrupt the cement column, and then you can use osteotome or the tibial component. Stem component will present a big challenge. So when they are smooth and fluted, they can be removed, but then porous stems are difficult to remove, and well-fixed cemented stem may be very difficult. Some of these stems have got thread holes for extractors. If they are not, then you may have to cut them with the high-speed cutting instrument, and really you may have to do an extended tibial to buccal osteotomy to get the stem out. So these are the special techniques like you do for compression fracture of the tibial plateau. You may make a window and try to tap it out, or you may use these special instruments to cut the plane. Now, for reconstruction, the most landmark technique was given by Kellyman, and he said you can reconstruct in 3 steps. In first step, you actually first achieve a stable tibial surface. Second, you establish the flexion gap, and the third, you establish the extension gap. So first, establish the tibial platform. So take care of the defects and do everything. Stabilize the knee in flexion. Flexion gap would often be more than extension gap. You have removed this component, which is so it's seen here, but you have to put this component, and you have to use posterior augments in order to fix the flexion gap. And then, of course, you have to restore the joint line. It's very important to equalize the flexion extension gap, because if you can't, you will have to go to an inch, which will take care of that gap. But then you have to use an oversized component and augment femoral condyle. And collateral ligaments are actually the primary check-in for the flexion gap, and the bone loss will lead to a smaller size. So you have to oversize, and you have to avoid the tendency to use a very big point. It's very important to maintain the joint line, because that will actually make sure that the result remains good. If you elevate joint line by more than 8 mm, it will be a poor result. So joint line elevation can be because of the distal femoral bone loss. So you have to use distal femoral augment, and then full extension is always preferred to a normal joint length. So if required, you accept some proximalization of the femoral component and accept some elevation of the joint length rather than leaving the knee in a flexion deformity. So that is how we look at the joint length on the table: 30 mm from the medial epicondyle, 25 from the lateral, and 10 to 15 mm proximal to the shoulder head. So the complications of a malposition in joint line, anterior knee pain, patella baha, and midsection stability. And the third step, according to Kelly, is stabilize the knee extension, which means the move the femoral component distally or proximally in order to equalize the extension gap to the flexion gap, and if required, use distal augment. And you can do a trial reduction with the least constraint insert so that you can assess the ligamentous integrity. Even if you have planned to use a constraint, you should test it with a least constraint device so that you will know what is the integrity of the ligament, and that will help you decide about the constraint. You have to also assess the bone defect. The principles have already been outlined for primary. You have to extend the same one, but it's very important to have the good fixation in all the zones, at least 2 zones, and then you have to make sure that you choose the right constraint. And of course, there are some people, particularly in the second phase revision, who will just sacrifice everything in the first stage of the debridement, take out the collaterals, take out everything, and then in the second stage go and put a in, and they have shown very good results at eradicating the infection. So in young patients, many times there was a question about the stem. So for decades, for the Genesis 2 and for the next gen knee, whenever I was putting a tibia in a young patient, I was putting a stem. There was a question about the thickness of the insert also. When you go beyond 14 mm or you put a constraint insert, you will need to put in a screw, and that will not fit unless you either have a taper plug or a stem distally. The taper plug and the stem would cost the same. So you would always put a stem in a young patient so that later on, if we have to convert it to a CCK or LCCK kind of knee for the Zimmer, you can just leave the tibia in place, put in the femoral LCCK implant, and put in a new insert. The same thing is applicable to the Genesis 2 as well. So availability of bones and metaphysical schemes have actually enhanced our capability to have fixation in the zones. So all of you are conversant with that. These are very good tools. They can actually take care of the defects and give added fixation. Particularly the schemes have made the revisions very quick. You can actually do very quickly what used to take you a long time to keep on fashioning the ends. And then of course these have a good track record where they have been shown to be very, very useful. Last part of my talk in the outcome, you must counsel the patient for every revision where they say for me, the results are the scores are suboptimal. They will not be like the primary TKR, and then the patients have to be told. But in this interesting paper, it was said that the failures of revision occurred in the first 2 years, then between 2 to 7.5 years, the results were almost the same, and then the worst results were those in patients in which the knee was failed. I would like to reiterate here something which has been said earlier by my friend Rajkumar also and many speakers. If you have a varus, the varus TKR will fail in varus. If you have hyperextension, it will fail in hyperextension. So remember that. Take care of the original pathology during the knee replacement, otherwise it will come to you with failure with the same mechanism with which you had first done the primary TKR in the first place. But then results can be reasonable, 89% in class survival at 11 years in this latest paper, and then not much difference in the score between the septic versus non-septic revision. So to conclude, do not revise if there is no cause. Pre-operative assessment is extremely important. Meticulous exposure and safe component removal with minimum damage to the extensor mechanism and underlying bone. Knee stability and restoration of joint line must be addressed to maximize functional outcome, and the patient counseling about prognosis is extremely important. Thank you very much for your patience.
Thank you so much, Professor Rajesh Malhotra. Both the topics are excellent, sir, especially why he needs failing. You told all the 10 points. Last point of the stiffness also, one of the point I feel post-surgical, most of the patients, they don't do exercises. They keep the knee in the same position and they come with 30 degrees FFD also, you have seen. I think that also should be highlighted, I think, in every step of counseling the patient. The second, the principles on management are good, and the topic is excellent. And one point which I want to ask you, I put on patient with Elizaro in post-infection after removing the implant. The reason is why you have Elizaro, then later you converted into
This was an 86-year-old man who had infection on both sides. We diagnosed it to be NTM, non-tubercular mycobacteria. Now he was bedridden because he had spacers on both sides. So what I did was the side which was worse on MRI had multiple sinuses. You know, in the non-tubercular mycobacteria, it's not like tuberculosis. In tuberculosis, you give ATT and the sinuses. In non-tubercular mycobacteria, you have to do vigorous debridement of all the sinus tracts and infected tissue. So I decided that if I give up the thought of giving knee on that side, debride, put an Elizaro, he will be able to put weight on it immediately. So that was the single purpose. So when I did this debridement and Elizaro, I got him out of bed the very next day, putting full weight because of Elizaro, and eventually healed. Then I took time to debride the other left side, put in a spacer, and when everything became alright, I went in and did a knee. So he has a fused knee on the right side, but a mobile knee on the left side. But the important thing was that he was already in bed for almost 6 months because he said he could not walk, so he was on a wheelchair. So doing this Elizaro made sure that on one limb, good limb, he could put weight and get off of the bed.
Thank you, sir.
Regarding this Klebsiella, which you mentioned, it's very dreadful. What is your protocol for Klebsiella regarding the antibiotics and the duration for the second revision?
So it is actually the Klebsiella is my sore nerve or my epilepsy. I'll give you an example. There was this army officer's mother-in-law who had 3 years back a spacer put in somewhere and the Klebsiella was there. So we found ESR-CRP was normal. We aspirated the joint, it was normal. So I took out the cement spacer and sonicated the cement spacer. Antibiotic impregnated cement spacer. Of course, by now all the antibiotic was gone. And it grew the same Klebsiella which was present with the 3 years back with the same antibiotic sensitivity. So what I am increasingly thinking is that if it's a Klebsiella, I don't want to leave anything inside, not even a cement spacer. I counsel them about because the mortality in patients with Klebsiella is very high. Most of them are colistin resistant, or if at all they are sensitive, they are only sensitive to colistin, and that makes it or polymyxin B, and it becomes a very challenging thing, particularly if they have a lot of comorbidities. So earlier they used to say Pseudomonas, but I say now Pseudomonas is not alone. Klebsiella has joined hands. And then even the non-tubercular mycobacteria is the problem. The lady who had to amputate, I'm still struggling with that. I amputated her, and after amputation, now last week she gave me 3 discharging sinuses. The extractology showed tuberculosis. It was good, 6 inches above the Tka. And when I sent the histopathology and this thing, it still came out to be tuberculosis. So now we are struggling whether it is the multi-drug resistant tuberculosis because she had already been put on anti-tuber treatment for 6 months. So Klebsiella, I always take the help of infectious disease specialists. Most of the times it is colistin resistant also. Sometimes if you are lucky it will be colistin sensitive, and then we have to be very careful, but then we do give them the antibiotic for at least 12 weeks. I'm sorry for the long answer, but it's something which is very difficult to handle.
Yes,
it's just to the
gram-negative is really a
this really thing havoc now, and it can be a combination of multiple polymicrobial kind of infection. That's another area.
Sometimes, in spite of the repeated attempts, we are not able to identify the organisms, and obviously killing it is infectious. So culture positive, culture negative. Do you make any, have any tips to deal with the prognosis difference, antibiotics?
This happens to us all the time. We are not able to, we have a patient who presents with discharging sinus, operated elsewhere. We do everything, we can't separate the bug. We go in, we do first stage, take out implant, we sonicate. Even then, sonication is not 100%, although that has improved our yield. we do tissue culture, we do everything. Patient CSR, CRP is high. He is post-operatively after debridement, he is oozing from the wound. Culture is negative. So if that removes only an empirical treatment, so we will give something like tazobactam, penicillin. The problem with this is that I would be tempted to use aminoglycosides, but the elderly patients who are diabetics, we just gave one elderly patient, we gave her 2 doses of the aminoglycoside, gentamicin, and she died of kidney failure. And that was the last day I gave anybody this thing, although it is used all over the world, but I said, like they say, your practice is decided by your last complication. We don't give, but I have a feeling that they are very good. So what we do now is we add aminoglycosides to stimulant. So we make stimulant granules and we put tobramycin in that. So instead of putting the fluid of stimulant, we actually put the tobramycin and mix it with that, and sometimes we are able to add one more antibiotic to that. The same thing we do about Klebsiella also. Sometimes we add colistin to the granules to avoid systemic toxicity, to give a very high concentration locally, and then go for the rest. These days are so much multi-drug resistant to keep NTM and fungal in mind. So we have had Candida and Pseudomonas combined infection, that also we have published. Any combination can just come in any bug. I have a patient who had ESR. ESR failed, so he had the device DHR, and he got typhoid and Preethi, and he got entered the salmonella type infection of the implant. Now he has had 3 debridements. Every time the salmonella type in the same stream comes out of him, we have just tried to eradicate that, but it gets onto the spacer, then we change the spacer, it comes again. So I think things are going to be very difficult. Infection, because I think not only infection is the complex cause, but infection is going to be the biggest challenge. Every day in my operation, I see some 50 new patients who need joint replacement, and at least 25 to 30 who are infected, who come from all corners of the country, and except from South. They come from Bihar, they come from UP, they come from J&K, they come from Himachal, Punjab, everywhere. Somehow I think we stop at Nagpur or somewhere when it comes to South.
Thank you.
How long do you space the screens? What center between the spacer and the...
So that's a very good question. So usually it is minimum 3 months, and we wait for 2 weeks. We do ESR CRP. You must always remember the antibiotic suppresses CRP. So if a patient CRP is continuously coming down, it's a good start, will more commonly be high. And so if after stopping antibiotics, ESR and CRP have come down, we aspirate. If that is negative, go ahead and do it. But then we still have a high suspicion. We sonicate the spacer and try to look for infection state. 2 more problems with that. One is that patients who are who have everything is fine, aspiration is negative, culture is negative, but CRP is high. I have never seen it mislead me in my life. So I will never go in planning for a second stage and implantation if the CRP is high. That's number 1. Now the rider is that the patient has inflammatory disease like rheumatoid or Rang's-Pond, then you are stuck, because the patient says that my ESR and CRP is always high, and possibly it will never come down to normal. Some of the diabetics, the CRP never comes down. So those are the cases which are very challenging, because on one hand, this is an immunosuppressed patient who is a diabetic, who's got inflammatory joint disease, and he is at more risk to have persistent infection. But then you can't rely on ESR and CRP because they are going to be high. So we take everything in consideration, the ESR, CRP and aspiration. But I can't tell you at least 10% or 15% will still grow something, and very often the same bug which was originally either from the sonication of the spacer or from the aspirate or from something. That's a real awkward situation.
Thank you, sir. Thank you, sir, for coming all the way and giving us all the lecture. You are enlightened, sir. Thank you so much.
Next, I call upon Dr. Rajkumar to talk on diagnosis and management of post-joint infection.
We had a very good discussion about infection. In fact, most of the aspects about infection was discussed in the previous talk. But let me continue on that aspect about this overview about diagnosis and management of post-joint, periprosthetic joint infection post-total knee replacement. So why do TPR fails? As the professor said, the causes are very obvious. Infection is the second most common cause, but there is all Western literature. I think in India, as the professor again discussed, that infection is going to be the first major cause of failure in post-total knee replacement. Incidence is 1 to 2% post-primary and 11 to 14% post-revision. But as we discussed, resistant microorganism and atypical pathogens are all is increasing and increasing. So we have to be very, very careful. Resistant microorganism and atypical pathogens like tuberculosis, fungi, all those things. So this is going to put a lot of mortality and the cost is going to be high. Not at all uncommon. These kind of situations are never uncommon in our part of the country. And this is, we can say that life is not fair for both the surgeon and the patient, for both of them. So how to deal with that? Our approach has to be very, very meticulous and the failure to know the treatment, to plan the treatment. We need to know the patient's comorbidities, soft tissue condition, how we are going to find out the organism and then the surgical protocol. All these planned proper approach is the one which will help us to treat. So these factors, everything is here, these factors are obvious and so common. We all know these factors are all associated with periprosthetic joint infection, and some factors are modifiable and some are not modifiable. Modifiable factors we have to take it before, consider it before the surgery, and non-modifiable we have to manage it as and when it comes. So the diagnosis is the most important critical part in periprosthetic joint infection. If we see like this in our outpatient clinic, the diagnosis is very much straightforward. We know that it is infection and we know that it has to be a two-stage procedure. But the problem is how to find out the organism. Even though the diagnosis is infection, before jumping into the management, we have to find out the organism. That is the biggest challenge. So to do that, we need to know exactly the pathology behind this infection. What is that? It is caused by three pathways. One of the three pathways. Either it is a perioperative, that is during the surgery inside the theatre. Next is the hematogenous, like UTA. We all know that UTA is a notorious thing. Other skin infections, dermatological issues, and then the direct contact. If the patient has got some other place or some other patient having. So all these things, but the perioperative and the hematogenous spread are the most common pathways. So again, as I said in my previous talk, any management we need to classify it to make our management very simple. The broad classification, but the most important one in the part of management is the acute and chronic. So what is acute? Around a month, 3 to 4 weeks. Less than that, if there is an infection, that is an acute periprosthetic joint infection, and more than that is a chronic. So whether it is going to be a hematogenous or a perioperative, acute or chronic, we should decide based on that. We have to plan our management. So look, coming to an example here, acute infection. This patient, 5 weeks post-TPR, diabetes. Look at the CRP, elevated, ESR is elevated, aspirated pus purulent fluid is, gram stain is positive, synovial fluid is, CRP is positive. So any aspirate, you do pieces of total count and the CRP apart from the blood, the CRP, and then this aspiration and the knee clinically shows that it is an acute infection. So the treatment entirely is different when compared to a chronic infection. That means this is almost like an emergency, septic arthritis. So we have to treat it immediately, unlike a chronic one. A chronic infection, again, one more example, 57-year-old male, painful limp, CRP is only 41, total count is 10,000, patient is having swelling, pain and limp. This is a case of chronic infection. So what is the biggest challenge? We need to know whether it is a pain is due to the infection or due to the flexion deformity, why it is, if at all infected, how to go about it. So we have the basic investigation of ESR and CRP. CRP is definitely one of the most important investigation to baseline. First we have to do that. But still that also has got some drawbacks. As Professor said, in an inflammatory condition patient, the CRP is not highly reliable. There are some drawbacks also. So in that case, aspiration plays a very important role. Analysis of the aspirate fluid for synovial WBC count, leukocyte esterase levels. It is in fact available in India, and then the culture of the synovial fluid. All these three things has to be done with the aspiration. And just to aspirate it and send the culture for 3 days, and the culture coming out as negative alone, it does not rule out infection. And this aspirate fluid, synovial WBC count, if it is more than 3000 in a chronic infection, then that means it is an infected joint. So we have to be very, very careful. And enough literature is there in the internet that this is the pathway for diagnosing an infection. So meticulous work has been done by Javed Parvezi and Thorsten Geriatrics, and they have published enough about this definition for periprosthetic joint infection. And this recently published evidence-based definition of diagnosing is the one which helps us to really get us into a pathway how we are going to diagnose the infection. If it is a major, they have divided into major and minor criteria. If it is major, it is very obvious. 2 positive cultures and then a sinus tract, it means it is definitely infected. Then, as I told you, we have to do both the blood, the CRP, ESR levels, and then the synovial fluid aspirate. Always remember, aspiration plays a very important role. And that is being scored, and some scores has been given. I mean, it is again more than 6, the score is infected, 2 to 5 is possibly infected. So this chart is definitely helpful. You can even see it in your clinic, and based on that, if you do your investigations and the criteria fits it, then you have to suspect. If for infection, more than the diagnosis, suspicion is the most important key in diagnosis. So the next important is the other markers, the cell count, alpha defensive leukocyte esterase. These are all called as the novel biomarkers and the molecular methods. Always remember, these are also very important, even though it is a reasonably, relatively a costlier affair, but still it is worth having it in your kit. So what is that? The synovial fluid test, as I told again, the CRP and ESR of the synovial fluid, not the blood. It is the synovial CRP, WBC count of the synovium. Again, look at this chronic infection. It has, if it is more than 3000 itself, that means you have to suspect infection. And then the leukocyte esterase and the alpha defensin. What is that alpha defensin? It is the synovial fluid biomarker, and the sensitivity and specificity is very high, close to 97%. And that is available here. Now it is around 9,000 to 10,000. It was 25,000, now it has come down. Along with the alpha defensin and the CRP, if it is combined, then the sensitivity and specificity is very, very high. This is the most important investigation, particularly in a chronic infection where you are having suspicion but there is no definitive diagnosis. So if the synovial fluid CRP is positive, then definitely there is a periprosthetic joint infection. So alpha defensin with the CRP is very important. Then the next important thing is next generation sequencing, NGS. But still there are some reports about this. Still it is not a confirmed one. But in a gram culture negative periprosthetic joint infection, this helps. It has isolated 90% of the time some sort of organism in a culture negative periprosthetic joint infection. So look at this chart. The most common is a staphylococcus. Coagulous negative staph aureus is the most important. Most common organism, 30 to 43%. Then comes the Staphylococcus aureus, then the MRSA, then the gram negative, 10 to 23%. That is actually huge for a gram negative, which is very, very difficult to diagnose. So treat. Then the next part is the manage. So what is the the early biofilm can be eradicated without removing the process. That is when that is the acute PGI. That's why I told either it should be an acute PGI or a chronic. If it is going to be an acute PGI, you can think about doing a immediate debridement and a poly exchange. What is that? It is called as the debridement antibiotic implant retention. That is a direct procedure that is possible only in an acute PGI. Remember that. What is the factors for success in that? Urgent basis. Emergency, if it is done, optimized medically, that means you have to optimize the patient medically also. Debridement as soon as possible. Just 3 more minutes. 6 to 9 liters of irrigation and exchanging the model. Wherever the modularity is there, please exchange it. So emergency situation, you are optimizing the patient medically, control the comorbidities, do a thorough debridement, poly exchange. Within first 1 month, that is 4 weeks, definitely the success is high. But
and I will have to do the 15%. So there are some interesting. This is a 78-year-old gentleman, Mr. Whelan, who had right-sided TKR done about 6 years back in the city.